Yeah, what did you guys think? That was the first time I guess I had seen something that said, well, maybe there is a subset that doesn't benefit from the CDK4/6 in the Paloma-3 with gene expression profiling on the primary tumors, even though this is metastatic disease. This is primary tumor and cyclin E overexpression there. That group really didn't get much benefit from the palbociclib. Retrospective hypothesis generating, right?
I think that's what Nick Turner's data showed as well in the metastatic setting.
Yes,
right?
yes.
So when they looked at the metastatic from the Paloma-3 and the tumor samples, those that had a low CCN, cyclin E1 expression had a higher PFS benefit compared to those that had higher baseline cyclin E1 expression had a lower benefit.
Yeah,
so
which
that was
makes
interesting.
sense, given the mechanism of action of the CDK4/6 inhibitors, and cyclin E1 is more CDK2, so it makes sense that if you're signaling through an alternative pathway, you may not benefit. So interesting, intriguing, and might help us in the long run, but still hypothesis generating, obviously.
I think it would be interesting if you could look at levels of gene expression and be able to assess the benefit in the long run, and maybe in collected trial populations we'll be able to, or in the adjuvant setting, because actually I don't think we know if cyclin E1 changes with progression of disease. Presumably it does, but I don't think we have a lot of data on that. No. I think it would be fascinating to look at it in the adjuvant trials.
We have known that cyclin E isoforms that are cytoplasmic predict a worse outcome. Kandan Keomarsi published that, gosh, over a decade ago. And if you look for what are the escape mechanisms that tumors can use, RB loss is one of them. We know that intact RB generally is required for CDK4/6 inhibition, but the other cyclins too that affect other parts of the cell cycle, E being the most prominent, are escape mechanisms. So eventually these will turn up. The cyclin E isoform isn't specific to CDKs, but I'm sure as time goes on we'll identify more and more. Fortunately, all of the trials did have tissue collection protocols, and we're seeing the first generation of these come out now. There's going to be much more as next-gen sequencing is done and as more deep sequencing is done on the blood samples.
And
so
we'll then know if cyclin E1 is altered with treatment. The other thing is that's associated with CDK2, right? Cyclin E. And so there are now, phase 1 trials with inhibitors of CDK2, 4, and 6, with the idea that would overcome some of the resistance. But I think this data, the Nick Turner data being the most, really the only data we have that's suggesting there might be something that would predict poorer response.
I think the other thing to probably see, which was interesting as well, was the data that he presented also alongside that this ASCO for PIK3CA mutations and ESR1 mutations from the same data set. So the ctDNA analyses, the paired samples that they looked at, it was interesting that patients who had a prolonged response and then ultimately progressed, those patients had emerging acquired PIK3CA and ESR1 Y537S specifically mutations. Kind of suggesting
on both arms.
On both arms,
fulvestrant alone.
It wasn't a CDK4/6 specific effect.
So it could be perhaps related to fulvestrant, and there is preclinical data suggesting that perhaps the Y537S might not be responding to fulvestrant as much compared to the D538G or the other.
Each one of these mutations is different. They all have different.
The other interesting data looking at progression in Turner's data as well, but in early first-line studies suggest that you get that ESR1 mutation, right? But then some of the patients lost the mutation over time, whereas PIK3CA mutations were preserved, which is interesting. I mean, it would suggest that there's a role for sequential therapy, even going back, say, to exemestane, everolimus after second-line CDK4/6 inhibition, because if some of the patients will lose their ESR1 mutation.
I mean, if it's by ctDNA, we might have to be careful if they are subclonal. And PIK3CA are more clonal mutations, and perhaps that's why they persist. So it depends, I guess. We have to probably keep a close eye on whether it's ctDNA or tumor, but they are definitely very intriguing. I think the PIK3CA story from Paloma-3, I think Paloma-3 has generated so much of this data, which has been very interesting. What was also interesting and caught my eye was Nick Turner's presentation about the decline in the PIK3CA mutant allele fraction, the ctDNA ratio, between day 1 and day 15 after you initiated a CDK4/6 inhibitor. And if you had the decline, you might respond to therapy if you are a PIK3 mutant. But if you do not have that decline in the PIK3CA mutant allele fraction by day 15, perhaps you're not going to respond with palbociclib. And I thought that was interesting.
Yeah, there was a pretty good correlation
to
with
develop
PFS.
I would
adaptive
keep in mind,
designs around
it's
that.
a subset, and
It
as
is
you
certainly
said,
a subset.
cell-free DNA, that one I think is probably the weakest correlation.
Yeah, yeah.
I agree.
But
agree.
it's really good that the CDK4/6 inhibitors were not bringing out differentially ESR1 and PIK3CA mutations. That was reassuring to me when I saw that, you know. But
And that the
so-
RB is low.
Oh,
That when
very
RB
low.
is
Yeah,
taken,
4.8%
I mean, you do
or
see,
something like that in terms
4.8%.
of came out there.